Welcome to myiacademy.com. I'm Professor Mahfouz Hussain from Jinnah Medical College, Pakistan. myiacademy.com is a platform for ophthalmic teaching for everyone. In this video, VHB Chapter 7, Section 1A, will discuss the bacterial and fungal keratitis, which is a type of inflammatory infective keratitis. The plan of the talk is we'll first describe the classification of the bacteria, then the classification of the fungi, then bacterial and fungal keratitis clinical diagnosis. Then in the next two lectures, we'll describe the treatment and complications of keratitis. First of all, classification of bacteria. Bacteria are classified into 5 main groups according to their basic shape. If they are spherical or round, they are called cocci. If they are like rods or flat, they are called bacilli. If they are spiral, they are called spirilla. If they are comma-shaped, they are called vibrios. And if they are corkscrew type, they are called spirochetes. Now, we will be mainly dealing with the cocci and the bacilli. So what you need to concentrate is that if the cocci are gram-positive, they are called gram-positive cocci. And if they are gram-negative, they are called gram-negative cocci. We'll discuss that in more detail in coming slides. The rods can be gram-positive or gram-negative depending whether they can take the gram stain or not. The prime examples of gram-positive cocci are Staphylococcus aureus, Staphylococcus epidermidis, and Staphylococcus pneumoniae. And the gram-positive rods are diphtheria and Corynebacterium cirrhosis, while the gram-negative rods are Pseudomonas aeruginosa and Enterobacter, which are Klebsiella, Serrata, Proteus, and E. coli. So these are the main bacteria which are involved in ophthalmic infections, and we'll describe now how to differentiate into gram-negative and gram-positive. Now, how do we do gram staining? Remember the mnemonic? Come in and stain. We use the crystal violet stain first, then the iodine treatment, then the alcohol treatment, and then stain with the safranin. So all the bacteria are here. First of all, the crystal violet, so they all turn into violet color. Then the iodine treatment, then the decolorization with the alcohol, and then the counter stain with the safranin. If the bacteria takes the safranin stain, they are called gram-negative, and if they retain the original crystal violet stain, they are called gram-positive. So that's how we describe or divide bacteria into gram-positive and gram-negative. Remember, the most common causes of bacterial keratitis or bacterial infection are Staphylococcus aureus and Staphylococcus epidermidis, which are gram-positive cocci. So gram-positive cocci are the more common cause of bacterial keratitis. Next, we'll describe the classification of fungi. Classification of the fungus is a bit confusing, and there are many terms used like yeast, mold, unicellular, multicellular, dimorphic, filamentous, hyphae, branches, mycelium, and spores. I've tried to make it relatively simple for you. Fungi, which are unicellular, are called yeast, and fungi, which are multicellular, are called molds. Now, next I will tell you the different forms of mold or different terminology used for mold. The mold is usually a branching structure, and the branches keep branching into smaller and smaller branches. So you can call these branches filaments, you can call them hyphae, you can call them branches, or you can call them mycelium. So all these 4 or 5 terms are used for the molds. So the molds can be filamentous or branches or mycelium or hyphae. You can use any term, and different books use different terms. Then some of the fungi are dimorphic, which means under certain conditions they are unicellular, and under certain conditions they are multicellulars. So both yeast and mold form spores during the asexual production, so the spores can be formed by the unicellular or multicellular. I hope that has made classification a bit easier. For an ophthalmologist, what you need to remember that fungi can be filamentous or non-filamentous. Filamentous can be septate or non-septate, and the septate then can be non-pigmented or pigmented. So first group is filamentous septate non-pigmented, also called hyaline or translucent, and the main examples are Fusarium and Aspergillus. These two are responsible for almost 98% of the fungal infections in the eye, so you need to remember Fusarium, Aspergillus, which are filamentous, septate and non-pigmented. The second group is filamentous, septate and pigmented, also called Demeticus or Phaeoid. Examples are Alternaria and Curvularia. The third group is filamentous non-septate, means they don't have any septa in their filaments or branches. The main example is mucor, and it causes mucormycosis. The fourth group is yeast, and the prime example is Candida. Next is the clinical diagnosis of bacteria and fungal keratitis or fungal and bacterial ulcers. So now we will discuss how to clinically distinguish between bacterial and fungal ulcers. Remember, most common is bacterial keratitis. So most of the ulcers are bacterial unless you prove them fungal. Look at these 5 photographs. Look at this one here. This one has got a ring and a bit more whitish in color. This is a bit hazy, less translucent, and this is again very irregular. Now you cannot guess which one is bacterial and which one is fungal. So remember, majority of ulcers are bacterial, so figure out the non-bacterial, and we are going to discuss that in the next few slides. There are certain points in the history which can point out whether the ulcer can be bacterial or fungal. Agriculture trauma points out towards the fungal keratitis. Immunocompromised patients have fungal keratitis. If more than one family members are affected, that points out towards bacterial keratitis, and the contact lens use points out towards acanthamoeba keratitis. Then are the classical clinical features that we are going to describe in the next 2-3 slides. Remember, the clinical diagnosis can be correct in almost 50% of the patients. Right, these are the points that clinically distinguish between fungal and bacterial keratitis. First of all, the infiltrates. If the ulcer is infiltrating into the stroma, like this ulcer is infiltrating into the stroma, then it's more likely to be fungal in origin. Feathery margins. Feathery margins are like irregular margins. You can also call them hyphate margins. So the hyphate or feathery margins are more likely to be in fungal keratitis. Then is the speculated, which means spikes or points on the surface. Look at the ulcer here. There are spiky points here. There are spiky points here. So these spiky points or points on the surface are more likely to be in fungal keratitis. Then is the dry raised margin. The ulcer is whitish and juicy, but look at the margin here. It's dry and raised from the surface. So that happens more commonly in fungal keratitis. And then is the elevated edges, which are rough texture. Rough means when you touch it with a needle, it has got a gritty feeling. This gritty feeling or rough texture is more commonly seen in fungal keratitis. Number 6 is the satellite lesions. Look at the ulcer here. The main ulcer is here, but it has got a small satellite lesions over here, here, and here. So these satellite lesions point out towards the fungal origin. Then is the endothelium plaque or posterior plaque. Posterior plaque means the ulcer has penetrated all the way through the descending membrane into the anterior chamber, and it has got an endothelium plaque. The next is the hypopyon. The hypopyon is convex and cheesy in fungal keratitis. This is hypopyon, and cheesy means it is like a cheese. When you change the shape of the head, the hypopyon doesn't change its shape that easily, and it is convex means it is convex like this. In uveitis, it's usually flat like this. Then is the pigmentation. If you have got the pigmentation on the ulcer, that is almost certainly because of the pigmented fungi. Then is the immune ring. Immune ring can be present in fungal keratitis, and you can see the ring here, which may point out towards the fungal keratitis, though it's also seen in the viral keratitis. Then is the collar button appearance. Collar button appearance is like a collar button. It has got a small, it is like a mushroom shape. So at the top, the ulcer will be big, but its attachment to the cornea will be relatively small. So it will be a collar button shape, and that points out towards the fungal keratitis. Next, we are going to briefly describe the investigations or laboratory diagnosis of the ulcers. We don't do the laboratory investigation for every ulcer. So when we do investigation, when there are atypical features or when we suspect fungal or amoebic keratitis, as most of the ulcers are bacterial and they heal with the commercially available drops, so we don't investigate every ulcer. Then if there's a deep abscess which is penetrating into the cornea, or the cornea is melting, or the infiltrate is large and central, or if the ulcer is not responding to the broad spectrum antibiotics, or if there are multiple infiltrates or multiple ulcers, so in these cases we normally investigate. So how we investigate? Very simple. The laboratory investigation consists of microscopy, gram staining and Jameson staining, culture and sensitivity, and latest techniques like a PCR. In the gram staining, we look on the slide for the hyphae. If the hyphae are present, that points out towards the fungal origin. Then we do the gram staining or Jameson staining. In the gram staining, you look for gram positive or gram negativity, and for the shape of the bacteria, whether they are cocci or bacilli. So with the help of the shape and the gram staining, you divide them into gram positive cocci, gram negative cocci, gram positive bacilli, and gram negative bacilli. Then in addition to that, you send the cultured plates for the culture and sensitivity, which usually takes some time. And now lately we have got the PCR, in which within 2 to 3 hours you can diagnose exactly which bacteria or which fungal is involved in the keratitis. Thank you very much for being with me, and please do give a feedback. Thank you.